We conduct this research about remote patient monitoring of ICD patients with heart failure because there isn't a lot of known about patient-reported outcome. RPM can reduce costs, can improve care of follow-up of ICD patients. But the question was, how does the patient feel this when the patient does not go to the hospital to his cardiologist? So our question was, what for influence has remote patient monitoring on the patient-reported outcome measured as health status and measured as patient acceptance? The technology we want to use is remote patient monitoring from Boston Scientific. It's a latitude system. It's a system that connects the data of the ICD to the server of the hospital. The latitude system is also connected to blood pressure cuffs and the weight scale. We included patients with heart failure, functional class 3 or 2, and an ejection fraction not above 35%. The patient underwent the first implantation of ICD, single dual chamber ICD or CRTD, triple chamber ICD. After implantation, patients were randomized in a 1-by-1 fashion into the in-clinic group. It's a usual care follow-up and the follow-up with remote patient monitoring. After implantation, the patient filled in a lot of questionnaire to measure the health status, to measure the patient acceptance of ICD therapy, and a lot of questionnaires to analyze the cost effectiveness. The in-clinic group were a follow-up every 3 to 6 months in hospital, and the RPM group was only seen once per year, and the follow-up were performed by remote monitoring. We included more than 600 patients in 32 hospitals in European countries, in Spain, France, Germany, Switzerland, and in the Netherlands. 300 patients were randomized to RPM, and the other 300 patients were randomized to usual care in-clinic follow-up. What we have seen is, during a follow-up of 2 years, that there was not a significant difference in health status or ICD acceptance. In both groups, in the RPM and usual care group, the health status was the same, with a trend to decrease during follow-up, because this population suffer from severe heart failure. What we also have seen, that the mortality rate in both groups was very, very low. 6.2% of the patients died during the follow-up of 2 years in the RPM group, and 7.0% died in the non-RPM group. That was very low. When we compare this, for example, to the REMOTE-CIED trial, the mortality over 2 years was 15% in the RPM group and 18% in the non-RPM group. We also analyze the cost of the follow-up with and without RPM. And what we have seen, that RPM produced a cost saving of about 22%. And this was mainly driven by less in-hospital visits. Clinical practice, we can safely use RPM, and we don't have to be afraid that the patients are not feeling good only to be seen via internet. And it is cost effective, it's cost saving. So I think we can expand our follow-up by RPM to save costs without worsening the patient-reported outcome. The database was locked several months ago. We are very busy with a lot of analyses. And one question we had, which subgroups benefit more or less from remote patient monitoring? The psychological profiles, I think, are very interesting to analyze which subgroup with depression, anxiety, concerns about ICD therapy does benefit more or less from a remote patient monitoring. Also, the regional difference in the different countries are also very interesting because, for example, in the Netherlands, it's a very small country, so the distance to go to hospital is very short. But, for example, in France or in Spain, the distance to the hospital is very long. So I expect that the distance to hospital may be one factor to get more benefit from remote patient monitoring than in huge towns.